Hey guys, welcome to this pharmacology drug class review in the category of bronchodilators, where we're going to be focusing our attention on these short-acting muscarinic antagonists. The short-acting muscarinic antagonists, specifically ipratropium, hit the market back in the 1980s. It's been a while, right? It's a well-established treatment for patients with acute COPD as well as asthma exacerbations, but also still a very cost-effective option for as-needed symptoms of patients experiencing shortness of breath in COPD. Hey guys, I'm Dr. Busti. Thank you guys so much for joining me on This Is Why, a show dedicated to helping healthcare professionals understand the why behind the pharmacology and the drugs that we use every day, because that helps us to understand how to manage patients easier. When those mechanisms start to come alive, they predict our therapeutic effects that we're looking for, side effects, monitoring parameters. It makes what we do meaningful and also makes sense. Now, with all of my drug class reviews, we cover core content, right? Things sometimes you have to memorize. Things like the drugs that make up this class, which is only one, thank goodness. You know, indications, uses, net benefit. What's the pharmacology? That's that mechanism, the pharmacokinetics, pharmacodynamic factors, and then we kind of bridge over into clinical knowledge, things of application that matter in improving the efficacy of not only the drug that we're looking to get a desired effect from, but also how's the patient responding to our treatment regimens for the diseases that we're managing. And with that, let's start out with our agents, right? Agent, right? Ipratropium bromide, but it comes in multiple dosage formulations. And so it is available in a metered dose inhaler form as well as a nebulizer format. And that makes it convenient for patients. And it's, like I said, it's been around for a long time. So it has a long history, long use, we're comfortable with it, and that makes it helpful, especially in the short-acting side of it. Because we do have long-acting muscarinic antagonists that have actually proliferated and grown, whereas the short-acting, there's really only one. All right, now let's move on to our indications and our uses. Now, straightforward at some level, acute care, it's really asthma exacerbation. There are formulations available for allergies, but that's not the focus of our conversation here, but just to be complete. And then COPD for chronic care. This is primarily in that situation. When you see asthma is only listed in the acute care for the acute exacerbation when we need something else to dilate. Then why would we do that? Well, because many times they're on a beta agonist already, especially a long-acting beta agonist, and so we have to find another way to bronchodilate them. So I put together these tables to try to wrap our minds around the diseases and why we use certain drugs the way we do. And it's important to understand that the approach to management of asthma and COPD are not the same. Now, these tables are available at thisiswhy.health for free. You can get that at the link provided in the description of the video or on the description at our podcast channels if you're joining us via audio only. Now, the difference between asthma and COPD is in part due to the cell type and then the problems that lead up to the manifestation of the disease, right? So in both of these conditions, there's inflammation. The asthma's underlying problem is eosinophils, more allergy and allergic reaction type stuff, whereas COPD is more neutrophil mediated, causes both inflammation but also remodeling of the airway, which changes the airway's compliance, adherence, even the surface area, and the airways collapse. But they make a lot of mucus. And this is where anti-muscarinic drugs or muscarinic antagonists can be helpful in that patient population that is struggling. Whereas you look with asthma, the mainstay of treatment in those patients is inhaled corticosteroids, ICS, inhaled corticosteroids as a maintenance preventative medicine. Then we add on usually like a beta agonist medication, and then the only time we would really go into the muscarinic antagonist, even long-acting, is in the patient who's uncontrolled, more severe, or has what is called overlap syndrome, which is this diagram here. So we have kind of like this Venn diagram where asthma and COPD can mix, where you have features of either one in your underlying main problem. And the reason that matters is that it guides the choices of drugs that we administer and why some patients benefit. For example, inhaled corticosteroids are the mainstay of treatment in asthma, but in COPD, it's not. We wait until they have more moderate, severe disease or they're not responding adequately to the other drugs, usually antimuscarinic agents or muscarinic antagonists. And so we add on steroids in those patients who are more difficult to control because they may have that ACOS, which is that asthma COPD overlap syndrome. And it's just really important to recognize that you may not know the type of underlying disease that your patient has, and sometimes it gets difficult, but part of the symptoms and the response to therapy drive us to see and experience that. All right, now we're going to move on to the net benefit of the drugs. Why would we pick this class? Well, thankfully it's pretty straightforward. It's a short-acting bronchodilator with antimuscarinic or anticholinergic properties, so it causes bronchodilation, dry secretions, and it can work in acute COPD and acute asthma exacerbation. Allows us another opportunity to bypass beta receptors if they're being occupied, and at the same time also dry some secretions. The other is the dosage formulation allows it to be a little bit more applicable across different scenarios. Okay, now we're going to move into the pharmacology. What happens when it gets, the drug gets to the site of action? How does it cause bronchodilation? When we say a muscarinic antagonist, what does that translate into cellular physiology? In order to understand that, you need to understand some of the basic anatomy. The drug is not going to work up here in the oral pharynx, so we're inhaling this. It's a topical inhalation. And we want topically to get the drug down to these distal tubes called the bronchioles, which are pretty far down here in the airway. But up all through that process, you see a lot of cartilaginous rings that hold the airway open. Okay? Those are not contracting, expanding very easily. They can get edematous, they can form mucus and secretions, and they can cause people to have bronchitis and symptoms. But really where the airflow regulation is happening is at the level of the bronchioles that lead to the alveoli, where that gas exchange for oxygenation, ventilation is taking place. And just to kind of zoom in a little bit further, and why that matters is that in COPD, we're going to see here in a minute that it's an obstructive airway disease. So if we obstruct the bronchioles and we don't get the blood flow coming in, or I'm sorry, the airflow coming into the alveoli, then the gas exchange is not going to happen, right? That CO2 is not going to get into the blood, and the exchange for the CO2 that was coming back from the body to be eliminated is not going to happen. So remember, when we bring air in or oxygen in, that's oxygenation. When we're trying to get rid of CO2 and exhale that out, that is ventilation. And we need both to regulate those two. Otherwise, it becomes imbalanced. People can get hypoxic and hypercapnic, and that usually in an exacerbation is one of the reasons why we would use this drug. Causes the hypoxia and the respiratory acidosis that the patient is manifesting on a VBG or ABG that we measure, or measure even their end-tidal CO2 levels. We can see that they're really high for whatever they are exhaling out. Now, when we look at asthmatic patients, they tend to have a hyperreactive, spasmodic airway. Again, underlying problem, eosinophils tend to benefit from inhaled steroids, but those steroids have to get into the bronchiole to prevent that spasm of that tissue. So this is a normal airway, normal thickness of the muscle, and then we see that as it gets inflamed and irritated, okay, it will spasm, and that lumen then gets compromised, and so the airflow through that lumen is now restricted. When you get more severe situation, you start making more mucus, and that forms mucus plugs, and so then the airway not only spasms, but then you have the mucus, and then that traps the air distal in that alveoli, and so that's why it's called an obstructive airway disease, right? You're air trapping at that point where gas exchange is going to be minimized, and you're not being able to ventilate or oxygenate in that situation. So we want to open those airways up, get the oxygen down there. In our COPD patient, depending on if they have bronchitis, which is usually like they have airways that are thick, edematous, they're making lots of mucus, so we can dry some of that up. But then over time, if we leave it untreated, there's restructuring and remodeling of the airway, and the airway loses its integrity and its compliance, so it just falls on itself. I mean, it just collapses. And that's what obstructs, and so they trap air as well, and they actually trap a lot of air They just cannot get that air out because they lost the elasticity and compliance of their airway. Well, you also change the surface area of the alveoli with that destruction. So gas exchange is compromised. You can't get the air out. You can't get the air in very effectively. Patients go through all these adjustments like pursed lip breathing, things to create positive and expiratory pressure to keep all those airways open. So we have got to get the drug down here where that smooth muscle is. And so once we get the drug down there, it binds to a receptor. And just like with the long-acting muscarinic antagonists that just have a longer duration of binding affinity and more specificity to a muscarinic receptor, they are able to do that for a long period of time, whereas ipratropium is going to still bind the muscarinic receptors with less selectivity than the long-acting muscarinic ones and exert its effect. Now, what we desire predominantly when we think about smooth muscle cells are the muscarinic subtype 3 receptors that would be the ones that you would focus on. But ipratropium is non-selective M1, M2, M3. And then when you look at some of the long-actings, there's subtle variations, always crossover at some level, never pure, right? Depends on how much you also give. But once you bind to that receptor, you're antagonizing it. Remember, it's a short-acting muscarinic antagonist, and that's why there's that negative sign being mediated down through that arrow on that muscarinic receptor. And what that does is it then reduces intracellular, inside the cell, secondary messengers like IP3, DAG that reduce the overall cytosolic calcium concentrations. That then translates into less interaction between actin and myosin. And when you do that, you relax the smooth muscle in that bronchiole, and that dilates it, allows airflow through. You get the gas exchange, but you're also, with the muscarinic antagonist, reducing secretion. So in COPD, right, that tends to be a little bit more of a problem than in asthma. And so that's why these are preferentially used in that patient population. Now, onset of action clinically is a little bit different what we see than what is sometimes reported in the product package inserts or drug information sources that sometimes you look at, where the onset could be up to 30 to 60 minutes. Yes, so that's a long time in an acute exacerbation, especially if someone is really breathing hard and is hypoxic or hypercapnic already. But you will start seeing some benefit actually within the first few minutes of it. And so, yes, you're not at the full maximum bronchodilation, but you're going to get some, especially if there's also the co-administration of a beta agonist that's occupying beta receptors. Okay, that's why we use sometimes both. Albuterol, that's a DuoNeb, right? Albuterol with ipratropium together being nebulized to maximize the bronchodilatory properties of the bronchiole itself. Now, structurally, this is a quaternary ammonium structure, which makes it charged. That makes it less lipophilic or more hydrophilic. And when you do that, you decrease the ability of the drug to pass through the blood-brain barrier. Well, that reduces CNS-related anticholinergic side effects or antimuscarinic side effects when you do that. Now, remember, we're administering these topically through inhalation, whether it's an MDI or a nebulizer. So you're not getting a huge amount. Some people say that's about 12 to 20% you absorb when you swallow some, it goes in your stomach, some of it absorbs in the blood. So there's a small amount. Well, we want to minimize the complications of it getting in other places because we don't want antimuscarinic properties outside of the lungs if we could help it. All right, now we're going to kind of move into that clinical application, and I want to first talk about getting the drug to that site of action. And again, if you've joined me on previous episodes or lectures related to bronchodilators, I hit on this hard, and I would want to reinforce it again here, not to minimize it, but to put it in the context of ipratropium, where we have two main dosage formulations that we can use, again, and using it with a spacer can maximize the efficiency of the timing and deposition of the drug down into the airways because of the timing problem when we activate the pressurized device. The nebulizer device, sometimes many people think that it's better. In reality, it's not. Many of the times the drug is coming out of these holes and into the patient's eyes, which can actually worsen their intraocular pressures and cause glaucoma. But you still have to use a proper technique. And so there's a typical steps that we go through that you've probably, again, seen or heard, or if, again, you've listened to my topics that I pound in because people just don't know how to do it. So when you're using a meter dose inhaler, you have to, it's a pressurized device. So you shake it to create maximize that pressure so that the drug that's being propelled out has a propellant or the amount of movement out of the device that is consistent from one dose to another. Well, in a nebulizer, you don't need to shake it, right? You just put the face mask on. But the next few steps are important. You still need to exhale out before you bring in that first dose, whether you're using a spacer, just makes it easier for timing, or you're timing it with the onset of the inhalation. Remember, so as you put your mouth up and you blow out, you press this down while you're breathing in. Not press it first, then start breathing in. It's while you're breathing in, and it's a slow, continuous, deep inhalation. Even if the mask is on your face, it's a slow, continuous, deep inhalation to try to get it down into those bronchioles, and then you should hold your breath for 10 seconds in step 5 to try to allow that aerosolized medicine to deposit on that tissue in the distal airways of those bronchioles. Otherwise, it's not going to do you any good in the nasal pharyngeal area. I mean, it may help a little bit with some symptoms, but it's not going to help open up your airways and increase airflow, right? And then you breathe out slowly. So you really want to try to coordinate with that. And if you're using it orally, or a pressurized device, there's 2 mechanisms of how you administer it by mouth. And when you do that, one is with an open mouth, as long as your lips are not occluding the opening. And same thing when you're putting your lips around it, that you don't block the movement of that medicine out of the pressurized device once you've already shaken it and you press it down and it comes out. Remember, in both of these scenarios here, you should already start to be breathing in so that the drug as it comes out continues to go down into your airways. When people look at nebulizers, why they like them is you put it on their face and you see smoke and makes you feel like that's better. The reality is it's just, again, getting in his eyes, which can increase his intraocular pressures and worsen if he has glaucoma. But he still needs to have a good seal. He needs to be taking good, deep inhalations with a pause and blowing out. So there's a lot of wasted medicine happening here, which is where the meter dose inhaler, especially with a spacer, can be, from an evidence perspective, has been shown to be equally effective, sometimes even better, because you're exposing the patient to less drug. And so when you come here, you want to time this is really important, but these mechanics here really maximize that deposition down into the bronchiole if you use the right, proper technique. Now, this drug, in the place of, when we think about it in the context of therapy, it's typically an adjunct. We're not using this as monotherapy all by itself in most cases, especially not asthma. Patients on COPD, it's not necessarily going to be harmful, but it is a cost-effective option. But when you add it in on an acute exacerbation with a beta agonist, you can actually get a decent improvement in the FEV1. 15% may not seem like a big deal, but anything greater than 12% is a positive bronchodilatory response, okay? All right, moving on to our nebulized therapies, okay, administration. Again, ipratropium comes in that formulation. That's a lot of what people tend to see, especially in the inpatient setting. But again, it can get into the eyes because it's spewing out of those holes. And again, the anticholinergic properties that can get in there will be absorbed and increase the intraocular pressure, and left uncontrolled can lead to blindness. Maximum frequency, typically in the acute exacerbation, we're administering 0.5 milligrams every 20 minutes, and we do that for 3 doses. Going beyond that in the acute really doesn't get much bang for the buck. You have saturated the receptors at that point. Now with short-acting beta agonists, sometimes we will go a little bit longer because remember there's that dose response shift that as they have more hyperreactive or spasm, it's going to take a bigger dose to overcome that because the duration is less. But we do kind of hit a maximum frequency and overall dose in COPD where we don't get much bang for the buck, right? So when we're out as an outpatient, chronically being managed for this in COPD, we're using it every 6 hours, the ipratropium. And that's why the long-acting muscarinic antagonists were developed. We can get away with, depending on the formulation, twice a day or once a day administrations. And so versus 6 puffs every, this up to 6 puffs, that's a lot every 6 hours throughout the day. It can be an inconvenience, but again, it depends on cost and availability, access, those kind of things. As it relates to special populations, the geriatric patient population is the one to be concerned about, especially those who have more comorbidities, glaucoma being one. And then number 2, you are absorbing this systemically. And so in men with prostates, we know that drugs with anticholinergic properties are more likely to exacerbate some of those symptoms. Again, we're not absorbing enormous amounts of this drug, but if you use proper technique, especially if you use proper technique and the method of delivery, but there is still some. And for some patients, that can cause enough urinary retention that leads to a UTI, prostatitis, discomfort, frustration, need to come into the emergency department, get a Foley catheter in just to drain them, right? So that can be a big deal for some patients. So applying it in the right context of the right patient and the level of severity with shared decision-making is important. Now, obviously, we're using a short-acting in the acute, most commonly, or symptomatic acute symptoms. We, sometimes need to monitor SaO2. That's obviously going to make sense. Our respiratory rate, make sure we have good, adequate oxygenation, ventilation. And then in our outpatient ambulatory care environment, making sure we have a baseline pulmonary function test with the FEV1, FEC ratio to monitor trends and appropriate response to these treatments. Okay. So this is the short-acting muscarinic antagonist, ipratropium, been around since the 1980s, long history, still being used, still very appropriate for both asthma and COPD exacerbations. Comes in multiple dosage forms. Remember, it's binding to those non-specific, binding to those M1, 2, and 3 receptors, causing that bronchodilation by reducing cytosolic calcium concentrations that prevent that actin and myosin from being released. Overall, fairly well tolerated, but if it gets outside or if you're using nebs, it can get in your eyes. So in patients with glaucoma, that's a concern. Patients with really uncontrolled BPH can have some exacerbation of their symptoms. Just keep those things in mind. But an overall effective treatment in acute situations, very helpful. So I hope that you found this to be helpful in the context of managing asthma and COPD, especially in the context of long-acting options, which are more for prevention. You need to know which tool to pick from when your patients have acute flares on top of chronic conditions, and how to manipulate the medications to maximize their quality of life, their symptoms, and keep them out of the clinic and having to come to the emergency department so we reduce utilization. That's a quality of life issue. So thanks so much for joining me. If you haven't already subscribed to my channel at YouTube, please do so. We really appreciate that, or I would appreciate that. Also, giving us a like, sharing, joining us at This Is Why Health. You can submit topics, ideas, questions, and I'll try to make them, future episodes. We'll give them certainly consideration. And so thanks so much for joining us. Thanks for investing in your knowledge, for learning why, because that's going to maximize your ability to do the how, which is managing patients effectively. We'll see you next time. Take care.